All right, we're going to be talking about neurodegenerative disorders. Okay, so I mean the name itself should give you a lot of indication about what you have in this case. So neurodegenerative. So there is neuronal loss, neuronal body loss, as a result of these disorders. Okay, and as a result of that, in normal brains, have 100 billion neurons. Do you guys know that? It's an immense number, really. So there will be, progressive loss of neurons. Now, this process does not happen haphazardly, okay? So this is, the group of diseases that we're going to be talking about is going to be, affecting actually a specific set of neurons. And, the neurons that are affected with every disease of the neurodegenerative diseases that we're going to be talking about are not related by physical location, or rather they are related by function. And that's an important, actually, distinctive feature to keep in mind when you think about neurodegenerative diseases. All right, so from there, actually, the fact that, those are going to be related to each other by the function they do, the neurodegenerative disorders are going to manifest itself by the pattern of neuronal dysfunction that the neurons, have lost as a result of the disease. So those that affect, the neurons in the cerebral cortex are going to result in loss of memory and cognitive difficulties. Those that are affecting the basal ganglia are going to result in movement disorders. Those that are affecting the cerebellar neurons will result in ataxia. Those that are affecting the motor neurons are going to result in weakness. Now, this is actually one feature that is going to, be a common denominator, when it comes to thinking about CNS degenerative diseases, is that it is a group of neurons that got affected by a disease that resulted in its loss, and those neurons are not actually in a specific location, but they share a common function. It could be memory, it could be cognition, it could be movement, it could be strength. So all of those are going to be, there's something to keep in mind as a first criteria. The second criteria is that across the different neurodegenerative disorders, you're going to be finding actually that there is accumulation of abnormal proteins. And that will make the histological hallmarks of these disorders. We will see that there are actually abnormal proteins that are shared among the different neurodegenerative disorders, but they are going to be in different places. And as a result of that, the presentation will be different, across the neurodegenerative disorders, okay? So the same proteins, for example, tau protein, the neurofibrillary tangles that are going to be seen across the landscape of neurodegenerative disorders. They are not specific to any disease. They can be seen in many diseases, but they are affecting different neurons, and the result will be different presentation in those patients. All right, so the third feature that you need to keep in mind when you think about neurodegenerative disorder is going to be the fact that actually the disease is a progressive one. So the disease may start by actually affecting the movement, such as what you see in Huntington's disease. But eventually, as the disease progresses, you will see that cognitive decline is going to, come on the stage as well. So it's a progressive disease because of the fact that actually the neurons that, are, sharing some functions are in different parts of the brain, and the disease may not actually affect all the different parts at the same time. It may happen, at the same time, it may happen sequentially. And as a result of that, you will see that the diseases across the neurodegenerative, landscape are going to be progressive in nature. Starting with Alzheimer's disease. Alzheimer's disease is is a disease with a huge burden. For a long time, we thought that it is associated with age, and age is actually the most important risk factor when it comes to Alzheimer's disease. But now we know, for example, now in the US, there are about 250,000 patients who have Alzheimer's disease who have, who are at 65 years or younger. So that's what you call actually early onset Alzheimer's disease. So it's a disease that have, higher, burden of both financial burden and, social burden. And that needs to be looked at and tackled according to the pathophysiology of the disease itself. Okay, it manifests itself insidiously. Okay, so it starts very insidious, but it's a progressive disease. So it will be chipping out actually from the memory of the patient. Starts with a mild memory impairment, and then it becomes more severe. Then more actually functions are going to be affected. Cognitive decline is going to be coming on the stage as well. Aphasia may occur as well. Eventually, a patient with Alzheimer's disease, after the diagnosis, depending on the circumstances that are surrounding the patient, may live between 4 to 8 years. If it's if you think about it as an average kind of time frame. And in some circumstances, he may live longer if there are favorable, especially social kind of support, network that are helping the patient, family and social network that are happening, around the patient that will help the patient cope with the burden of the disease. This happens in those patients from pneumonia or other infections. So it is the most common. Alzheimer's disease is the most common cause of dementia in the elderly population. Now that we have talked about dementia, you have to actually talk about dementia. It's a syndrome of a chronic or progressive in nature, in which there is a deterioration in cognitive function in a previously unimpaired person beyond what might be expected for a normal aging, and that is severe enough to interfere with person's normal daily activities and social relationship. It's important to actually keep that in mind, because you will see different definitions of dementia. So I opted to read it for you rather than to actually leave it like this. It's important to keep that in mind. This is probably the closest to what dementia is. Okay, now the dementia is not going to affect only memory. It will affect memory, it will affect cognition. Now, consciousness is not going to be affected in those patients. And the impairment in cognitive function is going to be preceded or accompanied by deterioration in emotional control, social behavior, and motivation. All right, so now what is the pathogenesis of Alzheimer's disease? If you are talking about Alzheimer's disease and you say the word beta amyloid, you're going to be right, because that is really what's behind the disease. It is accumulation of this protein that is going to cause the disease over time, initiating a chain of events that will result in the full-fledged Alzheimer's disease. So where does the beta amyloid comes from? It comes from actually a transmembrane protein. So this transmembrane protein is present in normal state. It's a transmembrane protein that is there, that is going to actually help the neuron in terms of its nutritional supply and in terms also of regeneration. And that protein, that transmembrane protein, is known as amyloid precursor protein. Now, the name itself is bad, because you're saying that actually, this proteins, if someone reads it without reading the background of the normal function of the protein, you would think that this protein is there only to give rise to the amyloid, that will cause the disease. In reality, it is a protein that has a important function in terms of the regeneration and the supplying of the neuron in normal state. And what happened here actually is that this transmembrane protein is going to be cleaved in what you call alternative splicing, process. because the normal splicing of the protein of the APP is going to result in soluble fragments that will cause no problem at all. But when another enzyme is going to actually have its way and splice this protein in its own way, it's going to result in the formation of insoluble fragment or insoluble fragments. That is known actually as the beta amyloid that will start to aggregate and will start to cause symptoms in those patients. So it is simply alternative splicing of that protein. Now what you're going to be finding is that there is a long list of disorders that may cause this condition. Okay, there's maybe a mutation in the amyloid precursor protein that is going actually to make the site that is going to be the normal site of splicing difficult to cut, difficult to slice, and as a result of that will open the door for the gamma secretase and for the beta secretase that will result in the formation of the beta amyloid that is going to result in the familial Alzheimer's disease, okay, that is going to manifest itself earlier than the old age Alzheimer's. Another way for it to happen is that if there is a duplication of the chromosome that carry the gene coding for the amyloid precursor protein, that gene is carried actually on chromosome 21. Now we know that there is something called trisomy 21. Trisomy 21, that means you have a third copy of the chromosome 21, which means you have a third copy of that gene, which means that you will have higher amount, of the beta amyloid if, the alternative splicing happen in those patients. That may open the door for, development of Alzheimer's disease in those patients. And now we know actually by evidence that the risk of AD is higher in those patients, in Down syndrome patient, than the rest of the general population. There are another actually way for the AD to happen, and that is in persons who have a variant apolipoprotein in their blood, known as apolipoprotein E epsilon 4. So the ApoE epsilon 4. Now each allele of the ApoE epsilon 4 is going to increase the risk of AD by 4-fold. Why does it do that? It does that actually because at least the presumptive etiology is that it includes aggregation of the beta amyloid. It makes it likely that if alternative splicing happens, that those beta amyloids that will result from this alternative splicing are going to aggregate on each other, deposit, or decrease the clearance of the beta amyloid, okay? Now, finally, actually, it is known now that patients who are obese or overweight have more likelihood to develop Alzheimer's disease. The reason for this is that the same enzyme that cuts the insulin, what is known as insulin degrading enzyme, also involved in the clearance of beta amyloid. So in those conditions where you have what you call insulin resistance syndrome, which is what you see with metabolic syndrome patients, what you see with type 2 diabetes, what you see even with pre-diabetes, you're going to be seeing that those patients are going to be awash with insulin. And you need more actually of the enzyme to cut the insulin, which means that the beta amyloid is not going to find actually the enzyme that is going to cut it. And as a result of that, it will accumulate and it will result in the disease development. So age is the most important factor when it comes to Alzheimer's disease. From 3% in persons who are above 65 to 74 years of age, all the way up to 47% in those older than 84. There is a long list of things that may actually result in this. You can go over them yourself. All right, pathophysiology. So when it comes to Alzheimer's disease, you have two proteins that are interplay here. One of them is actually the beta amyloid that we have just talked about that will give rise to what is known as the senile plaque. The second protein that is going to accumulate in that case is going to be known as the tau protein. The tau protein is going to form what is known as the neurofibrillary tangles. The accumulation of these two proteins, one outside the neurons, which is the senile plaque, and one that is inside the neuron, which is the tau neurofibrillary tangles, is going to assure the death of the neurons affected. As a result of that, neurons will be lost. As a result of that, disease will happen. Okay. Now, one point to make about this is that the beta amyloid deposition is relatively specific for Alzheimer's disease and is thought to be primary, whereas the tau neurofibrillary tangle is thought to be secondary and is not specific because it could be found among many different neurodegenerative disorders that we may talk about actually tomorrow in the rest of the lecture, inshallah. All right, so again, neuro loss, neurodegeneration or neurodegenerative disorders, that's going to be the Alzheimer's disease that we're talking about here. These slides come to you courtesy, these stills, if you will, come to you courtesy of the osmosis videos. I made sure to leave actually the tag right here so that, we keep actually, we're giving, reference to, where I got those slides from, okay? So again, plaques and tangles, what's gonna happen here? So the plaques are going to be accumulating here. The tangles are going to be accumulating within the neuronal body itself. So this is the transmembrane protein that we have talked about. Transmembrane protein usually normally is cut by the alpha secretase and the gamma secretase. The component that are going to be resulting from this, cut is going to be soluble. So they are not going to linger around and they are not going to aggregate. So this is soluble, no problem at all, okay? Now, if alternative splicing happen, that's when another enzyme actually comes into play that is known as the beta secretase. That could happen, as I just mentioned to you, because the area, of the alpha secretase is going to be, difficult to cut, or the alpha secretase itself is mutated. The gene coding for the alpha secretase is mutated, meaning it cannot work actually on cutting the ABB. So the end result is going to be a second enzyme is going to kick in gear, and that is going to be the beta secretase and the gamma secretase itself. The end result is going to be that the top portion that will result from this alternative splicing is going to be forming the beta amyloid fragment that is insoluble, okay? So that beta amyloid fragment is going to start to actually clump and starting to form what is known as a diffuse plaque, all right? Diffuse plaque that is going to be joined up by the tau proteins, the neurofibrillary tangles. The combination is going to be called actually the neuritic plaque, okay? So what happened actually? Now this plaque that has formed here, of course you don't need to worry about this diffuse versus neuritic, for your own information. Now what you're gonna be finding actually is that this plaque that has just formed here, the plaque that has just formed here is blocking the transmission between the two neurons. So there is no neuronal transmission between the two of them. So there is impaired brain function, okay? Impaired brain function, wherever those neurons are, we will see that actually this process is selective to only certain neurons. And as a result of that, certain functions only are going to be affected, okay? So there is disruptive, signaling happening as a result of the presence of those plaques, the senile plaques that have formed as a result of the aggregation of the beta amyloid clumping. Here's a very nice graph that comes to you courtesy of Robbins. There are two ways to deal with this APB, with the transmembrane protein. One of them is the non-amyloidogenic pathway, where the alpha secretase is going to take lead in cutting this APB, resulting in the soluble fragment, no problem at all, okay? When does that happen? When does the alpha secretase come and cut it? That's usually when this protein becomes aged, when it becomes old, and has to be, broken down and recycled for a new one to come, across. If there is a problem, if there is a problem with the alpha secretase, if there is a problem with the site of cutting on the ABB, the end result is going to be that, the beta secretase will take lead in cutting. That will result in the formation of a different fragment than here. This different fragment is what is known as the beta amyloid monomer that's going to slightly first aggregate, resulting in the oligomer, and then aggregate some more, resulting in forming the beta amyloid aggregates and the amyloid fibrils. Now that's really very important. Why? Because when the neuron sense that there is a senile plaque that has formed outside it, it's going to activate a certain enzyme known as the kinase. The kinase is going to hyperphosphorylate the tau protein. The tau protein is a protein that is entrusted in maintaining the microtubular function. When it becomes hyperphosphorylated, it will undergo a shape change, a shape shift, if you will, or a shape change, a conformational change that is going to make it aggregate on each other, that is going to result in the formation of what is known as the neurofibrillary tangles. That is going to make sure that this cell is going to die. Okay? All right, so the beta amyloid are toxic to the brain, to the neurons. When they worked on it in the lab, and they actually put the beta amyloid in vitro with neurons, it damages the synapses and kills the neurons. Okay? Now, this actually damage is not happening haphazardly. It's happening very selectively in areas of the hippocampus and the entorhinal cortex, areas that are severely affected in Alzheimer's disease, sparing cerebellar neurons, for example. And as a result of that, the functions that are going to be affected are going to be those related to the neurons in those two sides, the hippocampus and the entorhinal cortex, including memory and cognition. Now, this damage is going to happen after it's mediated by free radical. That is when the beta amyloid is going to combine with the zinc or with iron. And that's a very important actually thing to keep in mind, that there is a high correlation between the amount of beta amyloid that gets deposited and the severity of neurological dysfunction of Alzheimer's disease. All right, so another actually area where the beta amyloid is going to be deposited is going to be in the wall of the vessels. So now we have seen a couple of ways for the beta amyloid to wreak havoc, if you will, on the CNS. One of them is by simply actually aggregating in the form of senile plaque. An immune response may be elicited, may be incited. That is going to result in simply devouring actually of the neurons in that site. That's one way for that to happen. Two, there is actually the neurotransmission has been blocked has become dysfunctional as a result of the presence of the senile plaque. The third one is that the minute that the cell starts to actually feel that there are senile plaque that has accumulated outside of it, and neurofibrillary tangles in the form of defected tau proteins are accumulating within it, the cell knows that its time is up and will actually choose to undergo apoptosis on its own. Another way actually for damage to happen as a result of the beta amyloid formation, if you will, is going to be the deposition of this abnormal protein in the wall of the vessels. And when you have amyloid angiopathy, those vessel walls will become weak and they become leaky, and hemorrhage may happen in the CNS as a result. Here's an example of a vessel that is affected with this deposition of amyloid angiopathy that makes actually that vessel leaky, that may result actually in leakage of blood into the CNS, resulting in the formation of a hematoma in the CNS. Here is actually a histological section right here on the left that has been stained with Congo red. Congo red is going to light up the beta amyloid, and you can see that it has stained the beta amyloid. In order to make sure that this is what you have, you also take it a step further, and you go and so these are vessels actually. These are vessel walls that have beta amyloid in them. Okay, all of them are affected with this process. Now, to take it a step further in terms of diagnosis, you will do a polarization test. That's simply by adding actually a polarizing lens to your microscope and looking under the microscope. Now, those Congo red vessels are going to appear to have what you call apple green birefringence of the amyloid in the vessel wall. So that's going in a way to confirm your finding of the amyloid in the vessels of those cerebral cortical arteries. Here's an example of the effects of the weakening of the vessel walls as a result of the deposition of amyloid in those vessels. This hematoma in the left frontal area of this patient's brain, of these patients with Alzheimer's brain, is secondary to amyloid angiopathy. Okay. Now, if you look at the rest of the brain, you will see that there is a widening of the sulci, right? Widening and deepening of the sulci, and there is enlargement of the ventricles. So, as a result of the loss of the tissue that is happening in patients with Alzheimer's disease. Here's an example of amyloid plaque deposition. Amyloid plaque that resulted from the aggregation of the beta amyloid, that happened as a result of the alternative splicing of the APB. Now, the role of tau. So before that, actually, what does tau do? So tau actually is a protein that is entrusted in maintaining the microtubules. This is the microtubule right here. Microtubule is what looks like a track. It looks like a train track, if you will. And what it does actually, it acts as a cart, carrying track. The cart carries the nutrients across these tracks, across the microtubule from one end to the other end of the neuron. Okay, so it is very critical that this microtubule stay fixed, and are healthy. Now, what's going to make them healthy is the tau protein. The tau protein, as you can see here in normal condition, is evenly divided across the microtubule. It is there to ensure the patency of this structure. Now, what happened as a result of the activation of the kinase that got activated when there is neuritic plaque that are accumulating outside the neurons is that the kinase is going to add a phosphate group, again, hyperphosphorylation mechanism, that is going to add it to a tau protein. When that happens, the tau protein are going to undergo shape-shifting, conformational change that is going actually to make those tau proteins likely to aggregate on each other, two at a time, resulting in the formation of what looks like a triangle known as the Neurofibrillary Tangle. Now, where is this actually forming? I apologize because it's lower. This structure, the NFT, the Neurofibrillary Tangle, that is made up of those the shape changed, tau proteins are happening inside the cell itself. And where they will be actually getting inserted, they are going to be inserted into the microtubule itself. And as a result of that, there will be no longer transportation across this microtubule, and those actually neurons, the distant ends of those neurons, are going to die. And that's actually when the neuron itself is going to receive further emphasis that its time is up and will start to undergo apoptosis, and as a result of that, neuronal loss. Here is an example of a neurofibrillary tangle. You can see, if you're a pathologist, you can make it actually into a triangle. That's, of course, is actually a joke. All right, so here's, two, what you call a double whammy. So the senile plaque that are being formed outside the neurons, and the neurofibrillary tangles that are formed actually inside the neurons. The combination of the two will make sure that the cell is no more. The cell will undergo apoptosis, programmed cell death, and will die. And that's going to happen, as I mentioned to you, in selective regions, resulting in selective loss of functions. In the case of AD, is going to be, it's going to be memory and cognition. Here's an example, a comparison between normal brains versus Alzheimer's disease brains. You can see that the sulci are wider and deeper, and the gyri are narrower because of the loss of brain material, and the ventricles also are more dilated. Three features you see, to differentiate AD patients' brain from normal brains. All right, so gross pathology, as I mentioned to you, you're going to be seeing, more widening of the sulci, more deeper sulci, and significant atrophy with dilation of the ventricles. Microscopically, you're going to be seeing the two lesions that will make this diagnosis, the plaques, the extracellular plaques, and the intracellular neurofibrillary tangles. Now, one thing actually to add, I hesitated to add it, but I want you to actually know it. So both the above lesion may be found in very, very minute, again, the word is very, 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 very minute amount in normal individuals, okay, in undemented, elderly normal individuals. And so this is why actually the criteria to diagnose Alzheimer's disease is pathologic as well as clinical, features. All right, so now, a couple of questions comes to mind, which is more specific to Alzheimer's disease. Of course, the beta amyloid is relatively more specific to Alzheimer's disease, and it's thought about to be, primary process that will be followed by the tau accumulation, the tau, shape change and, accumulation or aggregation, causing, the formation of neurofibrillary tangles. Now, tau accumulation could be seen in other conditions, could be seen with frontotemporal dementia, chronic traumatic encephalopathy, myotonic dystrophy, and prions disease. And the tau accumulation is thought to be secondary. All right. Now, the second question, which is more in tune with the course of the disease? Now, amazingly enough, the cognitive decline correlates better with the NFT rather than with the senile plaque. A very important feature to do. So obviously, the NFT has more pathogenicity, if you will, more tissue damage, if you will, relatively speaking, to the SPs, to the senile plaques, okay? Now, having said this, it is important to note that the environmental association for AD have a stronger link to the amyloid, to the beta amyloid, than to, so I think you can make up your mind on this, that, which is more specific? The answer is clearly going to be beta amyloid, relatively more specific, because you may see beta amyloid in some other, condition. We'll talk about that tomorrow, inshallah, in the lecture. Now, which is more in tune with the cognitive decline of those patients with Alzheimer's disease? It's going to be actually the NFTs, the neurofibrillary tangle. In terms of genetic and environmental risk, beta amyloid is going to lead the way. Here is an example actually of what you call diffuse plaque. So what's the difference between, again, I don't think you need to know it, but I will say it anyways. So between a diffuse plaque versus a senile and a neuritic plaque, it is both actually made as a result of the beta amyloid aggregation. But with this one, you don't see the tau nearby. This one you actually do see the tau nearby, and this one you see gliosis. This is a reactive process from the brain tissue itself to cover the region that has been lost. This one, there is no reactive gliosis, and there are no NFTs, around it. All right, so here actually you see, a lot of gliosis, that is trying to cover what has been lost, and you see also plaques and NFTs, here and there. The same exact here, large numbers of plaques, okay, and also large numbers of tangles as well, which is going to result eventually in the loss of all those neurons and synapses. A differentiating picture between what you find actually, and just Alzheimer's disease. All in all, you can see, how thin the gyri are compared to normal, okay, and how deep and wide the sulci are. If you cut it, a coronal section, you're going to be seeing that the ventricles have dilated as a result of the loss of brain tissue on both sides. This is a neurofibrillary tangle right here. I think now, like, again, all jokes aside, it does look like a triangle to me. And, that's going to be composed of the tau protein, the tau protein that has undergone the shape-shifting, the conformational change that we talked about, could be seen in Alzheimer's disease and in other diseases as well. All right, so clinical features, we're going to be taking it with the neuroscience people, I'm sure, but, a couple of words, actually. So progressive disease, something to keep in mind for sure. That's within 4 to 8, other sources, 5 to 10. If the support, environment around the patient is good, this actually may go up to 20 years. Okay, complications of chronic illness and infections are going to be right there, as a cause of death for those patients. It is the 4th to 5th most common cause of death in the US, just to show you how common it is over there. And, the difference between early onset disease and, late onset disease. Late onset, in that case, that's going to be most commonly due to, old age, the most important risk factor. Again, not normal age, normal old age should never be associated with that much loss. And I mentioned to you that you may see actually very, 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 very little number of those actually, accumulation of beta amyloid. It will be negligible, to the point it will be negligible. But in those patients with Alzheimer's disease, it's all over the place, both the SPs and the NFTs. Now, that's actually the late onset. There is an early onset Alzheimer's disease. That's what you're going to be finding actually if there are any mutation in the gene coding for the alpha, alpha enzyme that cuts the ABB. If there is any, extra chromosome 21 that carries the APB. If there is, any risk factors when it comes to obesity or overweightedness. As a result of that, the insulin degrading enzyme will be needed to cut insulin and will no longer be actually working, or will be working very little on cutting the beta amyloid that may be forming. So the end result is going to be more beta amyloid. Those patients with the early onset Alzheimer's disease are going to present with a more severe disease, and also in a familial setting, okay, at a much younger age, 50, less than 50, and something to definitely keep in mind and ask about familial history when it comes to that. Okay, so this is it. In case you guys have any question, you may ask me now. We still have 15 minutes to go. Let's see the chat. Right, why the ventricle dilate? Well, because you have loss of tissue around them. So that's going to allow them actually space to dilate, if you know what I mean. So because the cells are sensing abnormal bodies, right? I mean, there is the exact mechanism in which actually the neuronal cells will sense the presence of SPs is not known, and honestly I did not dig that deep. I'm sure it's the work of a lot of actually research, but as far as I know, I don't think that it has been set in stone yet. Is there anything else? Which point? Can you please repeat that point? Which point is that?
Yes, doctor, good morning.
Hello.
Assalamu alaikum. So, doctor, you were mentioning about how the, I think, LDH, I think, the lipid inside the blood is a risk factor for the neurodegenerative disease.
Can you speak up, please?
Yeah, doctor, you were speaking about the connection between the lipid in the blood as a risk factor at the very beginning.
The lipid in the blood?
Yeah.
How is that? I never mentioned the lipid. The insulin, maybe?
Yeah, about the insulin. I think I misunderstand. Right. It was before the insulin point. Yeah, the apolipoprotein.
The apolipoprotein, right. They found out actually that the patients who have a special form of apolipoprotein E, okay, a form of lipoprotein that is present in all people. But those patients actually have a special subset of this apolipoprotein E. It's called epsilon 4, a special subset. Those patients are more likely, if they carry one allele of this actually subset of this protein, they are four times more likely to develop Alzheimer's disease. And the question was, the presumptive etiology. Just one second, please. So the presumptive etiology is. Just one second. Presumptive etiology. Right. The presumptive etiology is that if there is any beta amyloid that has been formed, okay, it will actually delay the clearance, which is going to make it more likely to aggregate with each other, okay? It may actually induce aggregation of this beta amyloid, induce its deposition, between the different neurons, resulting in the disease. You see what I'm saying? So there is association. They found that those patients are four times more likely, and that there is a clear relationship between how many alleles and the likelihood of developing those the disease itself. Does that answer the question?
Yes. All right, doctor. Thank you so much.
Anything else? Right. So, someone asked actually that regeneration neurons, again, like I told you, like in terms of regeneration, in theory it does have the ability. Of course, in practice it will not. It will take infinite time to do that. But in theory, it is there actually to do that. Now, if you want the actual function of ABB, you have to give me 2 seconds here. 1 second. Okay, here it is. Are you guys still with me on the lecture? Do you still see the lecture?
Yes, doctor.
Okay, good. Just 1 second. Right. Right. So ABB helps the neuron grow and repair itself after injury. Okay. So this is, you cannot go wrong with that. Okay, it is there. Again, probably, your idea is that, if you cut it will never grow again. I agree with you, but in theory it is growing, but it's growing as such an infinitely small, amount of growth that for all practical purposes, it is not growing. Okay. I think you guys are, pragmatic enough to figure out, the difference between the two. Anything else? All right, so I guess everything's good. All right, how do I send you? Thank you. How do I send you the lecture? Let's see if I can, can I? All right, wow, it worked. So you guys got the lecture now, right? It's downloading now. It's downloading. Hala. All right, so tomorrow, inshallah, is our next meeting at, I believe, 4 o'clock. Is that correct?
Yes, doctor.
Thanks a lot. Let's wait for this to download so that you don't lose the.